Thank you very much, Tracy. So yes, my name is Gráinne Kearney. I'm a clinical lecturer and an academic GP in the Centre for Medical Education, and my pronouns are she and her. So I'm going to begin this presentation this afternoon, and we're delighted to be involved in this conference. I've learned so much already just from being here from 2 o'clock, so thank you very much. So our presentation is on introducing cultural humility in the medical curriculum, and this is something we introduced this academic year 21-22, and you'll meet the rest of the team through the presentation. So I lead a module in our medical school where first-year medical students enjoy early clinical contact with patients, usually in their own home, led by GP tutors in the community. This is not only a highlight of the medical degree here at Queen's University Belfast, but it's a formative experience that shapes the kind of doctor these students will be in the future, the point where they often come to understand patients as people. And I say that from personal experience, as I was a student in this module myself 20 years ago, and hopefully you can see here the report that I produced at that time. And I still often now reflect on this experience as a GP of almost 15 years. So for many students, this early clinical contact is their first experience of getting to know someone culturally different from them, taking culture in its broadest sense. So we saw an opportunity to develop this through the introduction of cultural humility in this module, embracing the idea of becoming the student of the patient, aligning with the call for inclusion in Strategy 2030 and equity in the Sustainable Developmental Goals. So I'm going to pass over now to Dr. Maria Corrigan, who's going to tell us a little bit more about cultural humility.
Okay, thanks, Gráinne. I'm Maria Corrigan. My pronouns are she, her, and I'm a senior lecturer and EDI lead in the Centre for Medical Education. So as Gráinne said, she approached me to discuss how to integrate diversity into the early clinical contact programme. So we agreed that it would be good to introduce students to the concept of cultural humility. And over the next 2 slides, I'm going to briefly explain what cultural humility is. So in their paper, Cultural Humility versus Cultural Competence, which was published in 1998, Melanie Tarvalon and Jan Mary Garcia introduced the concept of cultural humility for training doctors to care for patients from diverse backgrounds. They developed it in response to the limitations of traditional cultural competence, which they criticised for encouraging doctors to learn objective facts about cultures, which can lead to stereotyping. The umbrella to the right illustrates how cultural humility doesn't just focus on race and ethnicity, but it incorporates individuals' multiple identities to include social class, sexual orientation, etc., all of which intersect to produce individual experiences. So what are the main components of cultural humility? So on the left, the diagram shows these components. Cultural humility is a process of lifelong learning and self-reflection. It encourages us to self-reflect on our own cultural identities and our conscious and unconscious biases towards different racial and ethnic groups, different genders, sexual orientations, etc. So cultural humility also promotes redressing power imbalances and promoting mutual respectful partnerships between patients and doctors. So, for example, promoting patient-centered medical interviewing when patients are respected as being experts in their health, and also when doctors are humble enough to admit when they don't know something. For cultural humility to work, institutions also need to be accountable and to reflect on their own practices and whether their processes contradict what is taught. So, for example, while we teach our students to use interpreters, they may see family members being used instead in clinical practice. We also introduced students to the 5 R's of cultural humility, which, although this was developed for healthcare leaders, we felt that it was useful in guiding students to apply cultural humility to their patient encounters. And I'm going to very briefly explain each of the R's. So the first R, reflection, encourages students to reflect on what they learned from each person that they encounter. The second R, respect, encourages them to reflect whether they treated everyone with respect. For regard, they ask themselves whether any unconscious biases interfered with their interactions. They then reflect on the relevance of cultural humility to their interaction. And finally, they reflect on how their personal resiliency and global compassion were enhanced by the interaction. I'm now going to hand you over to Dee.
Thank you, Mairead. My name is Dara Casement, but I always say to people that my name is Dee. and my pronouns are she, her. So within this project, we created a video embedding cultural humility early in the curriculum. And in this video, the concept of cultural humility was explained to students and for the GP tutors who would be facilitating student learning. You can see a copy of the video or a screenshot of the video on this slide. So video as a medium allows for a personalised message. With presenters on screen, we were more likely to connect on an emotional level with the audience members when using video and webcam when compared to other content formats. And we know as a format, video is more engaging and leads to higher retention rates. For example, 90% of information is visual, and it is proven that visual content is processed much faster than the same information presented in a text format. Albeit making recordings are time consuming, it does take planning, coordination and discussion. However, as a process, it makes presenters consider the information to be shared with audiences within a defined time frame. And it is important that video content is as digitally accessible and inclusive as possible. This means providing audio for people who can hear and subtitles for those who are non-hearing. And in addition, we also provided transcripts. Studies have shown that 7.5 million people in the UK do use subtitles or captions on recordings and videos, but only 1.5 million of this group are actually deaf. Captions and subtitles are used mainly by non-deaf people, but they're also used by those where English is not their first language. And studies again have shown that subtitles really do help with specific terminology as well as local accents. Along with this, we know that video formats are preferred by learners as they can be watched at a pace to suit the individual learner. The use of webcam made the recordings more personal, and it showed the presenters directly addressing their audience. Again, studies have shown that by being more personal, students are more likely to engage. It was very important for us to use the QUB branding. It was also really important that the images used demonstrated a range of people within medicine for many different cultures and disciplines. Images were also sourced using Creative Commons licensing and/or personally captured images. And of course, the biggest advantage of video is that it can be used and reused, and there's no further cost to time or effort. Once the video was viewed, we carried out a mini workshop called Have You Ever? And we gave students a number of prompts over Mentimeter, again thinking of culture within its broadest sense. And students could respond anonymously and instantly to the statements that were presented. There were around 10 prompts, and we were careful about commenting on themes as to not bias student responses. I will now pass you over to Ariana.
Thank you, Dee. My name is Ariana Asha. I'm a third year medical student, and my preferred pronouns are he, she, her. To allow continuity in students' learning experience of cultural humility, we got the GP tutors to talk about their contact with their patients using the 5 R's framework, once at the start of the module and again at the end. Finally, we asked students to reflect on this concept in their blogs, which they produce as part of the summative assessment for this module. Next slide. Following good teaching practices, we evaluated the students' learning using an initial survey just after the reflective exercise workshop and the introductory video they mentioned. From a total of 312 students, 188 responses were collected from this survey. Quantitative data measured students' understanding and perceived importance of cultural humility, as well as their level of preparedness in using cultural humility in clinical practice. Next slide. The mixed method approach we used also helped us to collect qualitative data about student experiences. The free text responses from surveys highlighted how students feel about their own experience with learning and practicing cultural humility. We have chosen 2 responses to illustrate. which I will now read. I am so glad to be doing cultural humility as part of our curriculum. If I'm being honest, one of the things I was worried about with coming to an ordinary Irish medical school was that there would be a lack of attention to issues of diversity in ethnicity, race, gender, and sexuality. I am not only thrilled to be part of a course that wants to produce socially conscious, kind, and sensitive doctors, but I feel very privileged and grateful that our teaching is deeply aligned with producing human-focused clinicians. Another first-year student added, I feel like cultural humility is a long overdue model to be adopted in medical schools, especially in the increasingly multicultural society we now live in. A number of issues can arise in medical practice as a result of the unconscious bias and stereotyping by medical professionals. Cultural humility should aid in alleviating these issues. We will also be using the blogs written up by medical students as well as informal feedback from GP tutors on their role in introducing cultural humility into early clinical contact. These will ultimately enable us to provide better resources for students and more support for tutors. I will now hand over to Grania.
Okay, so we've been really pleased with how this initiative has been received by our students and GP tutors, and so we've been making some plans about how to further develop this. So we have ethical approval for research into this initiative. We've already talked about the surveys, collecting both quantitative and qualitative data, and also we have access to the blogs of some consenting students to analyse in more depth how they have tried to apply their learning on cultural humility to their early clinical contact with patients. In addition, we plan to extend this initiative into the third year of the medical curriculum. We hope to build on what they've learnt as they gain more clinical experience by developing the critical element of cultural humility to prompt these more senior medical students to consider the power differentials and how they play out in clinical relationships, something that we hope that they will continue to be aware of in the future when they are doctors consulting with people. So that brings us to the end of our presentation. Thank you for listening and thank you for involving us today. And we will be taking questions, I understand, at the end.